Yes, Dr. Chinmay, I can see your screen now.
Okay, I don't think there was some issue or something like this, like invalid screen application or something. Okay, I'm glad it's okay now.
Yes, yes, it's perfect now, and your voice is also audible.
Okay. And what about like my video? Because I think I need to. Should I join it with my phone?
Yes, sir, you have to join it with your phone and you have to open the
Uh,
video.
yeah. Okay. Just a minute. Hello.
Yes, Dr. Chinmay, we can see you.
Yeah. Okay. Yeah. Okay. Great.
Let's wait for like 5 minutes so that all the students can join in and then we
Yeah.
can
No
start the
worries. No
video.
worries. Yeah. No worries.
Sure.
No worries.
हम्म
अनि रेकर्ड पनि हुन्छ नि अनि त्यही त्यसरी 2 हप्ता क्लास लिने अनि त्यो क्लास लिएपछि चाहिँ अनलाइन क्लास अनि 1 हप्ता चाहिँ उनीहरूले सिकाउँछ अनि अब त्यस्तै 15
Hello, everyone. Hope you all are doing great. So let's get started with our webinar. So let me first give you an overview what Med Exam Expert is offering you for your AMC1 best preparation. So we are offering a regular course, which is best for the students who are appearing for the February exams or March exams who are planning for the next year, okay? So this regular course will help you to boost up your confidence, to have the best preparation by covering all the important topics in 42 interactive live sessions in which there will be our best mentors, Dr. Sumaya, Dr. Farhad, Dr. Chinmay, and Dr. Nabira, who will be there for your guidance for your best preparation. And apart from the live sessions, we are going to provide you the recording and the PDF of all our live sessions. And we're going to provide you the psychiatry workshop that will really help you to ace your psychiatry module that is best for your AMC exam. And then apart from the live sessions and the recording, we are also going to provide you the recall session recordings that will really help you to cover all the recalls. And then for the question practice, we are going to provide you the question bank that will contain 5,000 plus questions along with correct answers and explanation. Then we're going to provide you the mini mocks and quizzes that will really help you to prepare the topics thoroughly. And then by the end of the course, we're going to provide you 3 mock exams that will be just like your real exam, just to boost up your confidence so that you will be well prepared before your real exam. And then apart from all these things, if you need any books, if you need any important files, or if you need notes and the flashcards to complete your theory, then we are going to provide you everything that you need for your best preparation. So for all the students who are planning to appear for the November exams, then for those students, we have a recall crash course that is specially designed for all the students who are appearing for the November exam, because you have like 2 months. In 2 months, we are going to give you the recall based live sessions in which all the recalls will be covered topic wise, and all the topics that are important for the exam will be covered in this. And apart from this, we are going to provide you the topic tests, quizzes, and everything that you need for your best preparation. If you want any details regarding all the courses that we are offering, or course counselor numbers are given in the chat box that will really help you to guide you about the upcoming courses. So these are some of the reviews from our beloved students who have joined us for the AMC Part 1 courses. They have shared their expressive, emotions regarding the course, what were the sessions, how they have joined, how the mentors were teaching them, and about the course content that we have provided them for their best preparation. So these are the reviews from our Recall Cash Course students. These are the reviews from all the students who have joined us for the live sessions, and they have shared their reviews with us. And these are reviews from our past students who have joined the course and they have passed the exam as well. So these are some of the reviews that we are sharing with you. So I guess that's all from my side. Now I would like to request Dr. Chinmay, are you available? So meanwhile, Dr.
Hello,
Chinmay-
everyone.
Yeah,
I'll just
hi.
share my screen now.
Sure. Dr. Chinmay, we can see your screen now.
Wait, I'll just
Sure, you can take your
just a
time.
minute. I'll just open the notes. Is my I think because your voice is bugging. Is my voice bugging too?
No, it's perfect.
Okay.
Yes, we can see the screen now, and your video is also good. So now we can start.
Okay, you can see the screen now. Okay, I think I'm not able to see, but you guys can see the screen, right?
Yes, right.
Okay. So hello everyone. So glad to see everyone over here joining the session. Welcome myself, Dr. Chinmay.
Dr. Chinmay, your mic is turned off.
I'm so sorry. I don't understand what seems to be the problem. I think
No,
my phone
fine
got
now.
disconnected.
We can hear you.
Okay. So can you guys can you just give me a quick heads up if you can see the screen and can hear my voice?
Yes, it's perfectly all right.
Can you just give me a little heads up in the chat? Okay. Great. Okay, so myself, okay, now it seems great. Okay, myself, Dr. Chinmay Trivedi. I've just cleared my AMC1 exam in the month of June, and I'm working as right now as a resident medical officer. I finished my MBBS last year, that is in 2023, and I'm from India. Okay, so today, I think what the content of the seminar seems to be that okay, it's buzzing in and out. That's why. That's why it's Dr. Hanif. Maybe it's not audible. That's why. Oh God. Okay, I think it's okay now. Okay, so we'll start. First of all, I want to go through what are the contents and what we'll be discussing today. First of all, I would like to give you a little flavor of what seems to be what you need to go through. Okay, so before we can go jump to the the core AMC stuff, I want to know that what are all resources that you can use. So for example, you guys, first is obviously the handbook, right, of AMC. See that you can see. Please pardon my handwriting. I know it's bad, but I'll speak it accordingly so you guys can understand. Okay, so first is obviously the handbook of the AMC that you need to go through. Then other online resources that are available, which includes hello everyone.
Yes, Dr. Chinmay, you can continue.
Okay, I don't understand why it is buzzing. So the network from my side is okay. Can you maybe point it out what seems to be the issue? Because it's like buzzing in and out the from my video. Okay, are we good to go? Can just someone say yes in the chat? Hello.
Yes, Dr. Chinmay, it's fine now.
Yes.
Okay. I will keep asking you the feedback from the chat box. So if sometimes if anything happens, please just let me know in the chat. Okay, so I'll stop and try to solve it. Okay. So I think now it's okay. So I was going through the resources that you need to go through first of all. One is obviously the handbook of AMC. Okay, I changed my Wi-Fi now. I hope it works. Um, I just hope it works now. I changed my, I shifted to the another Wi-Fi. Okay, okay. Yeah, I think so. Yeah, about see, saying it's better to join from the same device without the video. I think yeah, that's that. I think that can work better. So if it still buzzes out, I think I'll do that. Okay. Thank you for the feedback. Okay, so I was going through the handbook one, and then another is online resources. There is RSEGP, RCH, that is for pediatrics. Okay, but then there is Renzo that is available. Okay, so that is for the obs and gynae. Okay, so what I mean to say from this is that whatever you are studying, it needs to be very, very authentic because AMC is too much guidelines based, right? So you need to be very thorough with the guidelines. Okay, and which I think that is exactly the reason why it's better to join some academy or something so that you can have a clear destined path like this how you should be following. Okay, there's so means many people who do it on their own, so it depends on you. So how do you want to perform it? Okay, and the third is then you must go through something called up to date, and there's also this therapeutic guidelines that is available. Okay, so these are some of the resources which I think will be very useful for you to use. Okay, and I understand that many people who are joining this webinar, they are from India. Okay, so for the people who have been preparing the exams from India, it's a very common practice that we are under this impression that you must be preparing everything. Okay, but that's not the case. Okay, for the AMC, I think it's better to be very constricted because as far as the AMC exams is concerned, and trust me when I say this, because I've gone through a lot of recalls, okay, of about like last 2 to 3 years, and every year, like I'm not saying they repeat the questions, but yes, they do repeat the concepts and they do repeat the topics. So that is why it's very, very important to to go through the question banks, to go through the all the recalls and everything so that you can have a touch of what all is supposed to get done, right? So that is one more thing that I wanted all of you to know, right? That be very, go through the recalls, okay, go through the question banks, and that is how you will know that what you're supposed to study. Okay, so talking about the contents for the lecture of today, there is some topics that we'll be reviewing, okay? And after that, we'll be discussing and also in the great detail. Okay, so I think I've handpicked a few topics, which is very, very conceptual. Okay, I've only picked up the highly conceptual topics from the neurology, from the cardiology, and from the maternal health. All three of them being the very, very important. Maternal health is super, super, super important. I think that it's not possible to pass this exam if you are not very thorough with the obs and gynae, that's maternal health, with psychiatry, that's mental health, and that's child health. These three are, I think, the standing pillars. Okay, so you need to be very thorough when it comes to that. Okay, so again, for my Indian audience, I think that we don't do the obstetrics in that much detail, but when it comes to AMC, I think it's a very good idea to go through each and every guidelines. Again, going to the resources for the obstetrics, there's one more South Australian guidelines that is available that you can go through. Okay, maybe you can take the screenshot or just note it down if you want. Okay, so let's start with some contents. Okay, we'll start with the transient ischemic attack. Okay, to well with is my am I not like clearly audible? Can someone please confirm?
Dr. Chinmay, you are audible now.
Okay, okay. So someone in the chat who said that I think it was slow connection. Okay. So first is I want you to know about the transient ischemic attack. So when it comes to CNS, stroke is very, very, very important. Okay. For some of you, I think you must have read it in the flyer that I've done the AHA certified BLS and ACLS workshops, and I cannot stress more on the fact how important it is because AMC asks a lot of questions from the emergency medicine and the stroke and everything that it includes that. Okay, so first of all, what is transient ischemic attack? Can anyone just quickly write it in the chat? What is the difference between a transient ischemic attack and a stroke? Does anyone know that? I'll just quickly wait for just because I want this session to be very, very interactive. I think that is the best way, we can help each other. TIA and stroke. The symptoms are same, but yes, Dr. Shuma, very good. The stroke are resolving within less than 24 hours. Yes, that is the very standard definition of transient ischemic attack. Yes. So if the symptoms, symptom-wise, the clinical onset was everywhere. The TIA and stroke is same. The only difference between the two is the time duration. Okay, that is that if the stroke symptoms they resolve within the 24 hours, we call it a transient ischemic attack. Okay, and if your patient is presenting to you in this time frame, okay, so it's very important to follow the protocol. Again, a golden tip for AMC, it's very important to follow the protocols, the all this, this flow charts. This flow charts should be crystal clear in your head, okay, because they will directly ask the questions from this. Okay, so neurological symptoms. Okay, first we see you need to take the rapid history. What are the neurological symptoms? I think when it comes to stroke, we remember one mnemonic, which is fast. Okay, so if there's like facial drooping, there is speech. Okay, then there's time duration. Okay, this is the mnemonic for that. We need to look at all those things. Okay, if the face, is the one side of the face, is it drooping? Is it the speech is not audible? Okay, and the time, in what time frame is it developing? Okay, so it's very important to know this neurological symptoms. Okay, so is the stroke or TIA likely? So based on the symptoms, you need to know that whether it's likely or not, right? So if it is, okay, see, we'll also be looking at the TIA mimics, okay, that's transient ischemic attack mimics. So if the stroke and the symptoms are not, because you also take the vitals, you also know the history. History is very important. Okay, when it comes to the stroke, you mostly find the history of hypertension, right? The patient is on the anticoagulant, patient is having some history of the cardiac catheterization, so that history is very important. So if that is not compliant with the the stroke, then it can be some another thing, that is TIA mimic. We'll go through that. And if it is a stroke, then yes, then whether it is the time duration, if it is more than 24 hours or not, right? So if it is, okay, then you need to know that whether it is within the 3 hours of the symptom onset, right? If it is, then you need to rapidly refer the patient. Can someone tell me why? Why do we need to refer the patient? 3 hours is said to be the gold standard, the gold standard timing when it comes to the stroke, right? So someone tell me why it is the gold standard timing, the 3 hours? By the way, AHA says that there is Australian Heart Association, it says it to be the 4.5 hours, but for the Australian guidelines, we'll go with 3 hours. Okay. That's a time frame. The 3 hours time frame, that is a time frame for your, in this time duration, you need to catheterize the patient. You need to either go with the thrombolytics, or either you can go with, the cerebral catheterizations. That is important. You need to put in a stent in this time frame, right? And if it is not, then you need to look at, you need to anyways refer the patient to the tertiary healthcare center. This side is if it is, presenting to you within 3 hours of the symptom onset, and if it is not, okay, then it is TIA is more likely. Okay, it would be just a transient ischemic attack which resolve within 24 hours. Okay, then you need to look at the ABCD score. Okay, what is it? ABCD2 score. Okay, so ABCD score, I'll zoom it out for you guys. You need to see A is for age, more than 60 years, B is blood pressure, C is clinical symptoms, that is unilateral weakness and speech impairment. Okay, so you also look at the points, the 2 point and 1 point. Duration, if it's more than 60 minutes or if it's 10 to 59 minutes. On that basis, you'll give 2 points or 1 point. And then diabetes mellitus. So ABCD2 score, much like Shadwell's score, okay, again, not regarding to this topic, but like Shadwell's score, this score is also very important. Okay, so if this ABCD2 score, okay, if it is more than 4, okay, and if there is a history of atrial fibrillation, some crescendo transient ischemic attack. What is a crescendo transient ischemic attack? If there has been TIAs, 2 or more TIAs within a week, okay, and some carotid bruise, so we'll say that's this TIA to be a high risk TIA, right? So for the patient who is at the high risk, again, the same protocol, what we saw that if the patient has presented for more than 24 hours, same protocol will apply over here. You will urgently refer the patient. Why? For the to the some stroke clinic. Okay, and if it's not, if the patient is not high risk, then you will run some other tests. You will go with the blood test, you will go to the ECG, you will do the CT brain and carotid imaging. Okay, carotid imaging, another very important question they ask a lot. AMC loves this question. Okay, so because now see, if the patient is not high risk, so what is your priority now? You need to look at what caused this stroke, right? So to look at the causes of the stroke, you need to look at the CT or MRI and then the carotid imaging. Okay, so when you do the carotid imaging, that is nothing but just USG carotid. Okay, you just look at how much is the carotid artery stenosed or not. Okay, so if this over here the borderline is 50%. Okay, again according to it changes. Okay, according to RCGP mentions 70%. Okay, so, sometimes there can be some discrepancy with the guidelines, but AMC wouldn't do it like this to you. They would ask you the simple questions. Is someone speaking? I'm sorry. Okay. So up there now you see if the stenosis of the carotid artery, if it was more than 50%, okay, then again, if it's a more than 50%, then you need to urgently refer, because that would have, curbed the blood circulation to the brain, and because of the dearth of blood in the brain, that could have caused the stroke. So you will need to urgently refer the patient for the end arterectomy. Okay, carotid end arterectomy. That is the name of the procedure. Okay, and you need to do it within 2 weeks. And if it is less than 50%, okay, then you just need to put the patients on the antiplatelets, anticoagulants. You need to put them on aspirin. You need to put it on clopidogrel, okay, and all those drugs. Okay, statin therapies, you need to start with atorvastatin, rosuvastatin, okay, antihypertensive agents, and then address the SNAP. That is, you look at the lifestyle modifications, that is smoking, nutrition, alcohol, and physical activity. Okay, so this is how I think the algorithm, I hope the algorithm is very clear in your head, okay, because they ask a lot many questions from this. Okay, first you need to differentiate between the stroke and the TIA. Just remember 3 hours time frame. If it is within the 3 hours of the time frame of the symptom onset, then you need to rapidly, refer the patient. In what case? In what case? Can someone tell me when do we need to refer the patient? Only when the symptoms have been for more than 24 hours. Because then only it fits the definition of stroke, right? Because other than that, it can just be a TIA, right? And for the TIA, if it's presenting to you within, like the patient says that it started like about 2 hours ago and then it subsided, okay, then you just need to rule out the cause. It's not a call for emergency. Someone asked me a question, Dr. Shubham, which antihypertensives are preferred? Okay, you can start with, it's a normal, okay, the antihypertensive algorithm, which happens everywhere. You start with the ACE inhibitors and then aldosterone receptor antagonists. So you can very well start with the captopril, you can start with the amlodipine, okay, and if it's not working, then you can just move forward with the calcium channel blockers, that is the lifidipine, okay. So the algorithm remains the same, okay. The same antihypertensives are used over here as well. So there's no such one preferred antihypertensive for that. Yeah. Okay, but one thing you need to take care of. Okay, there's one antihypertensive because you have asked about it, which is nimesulide. Okay. So if you are doing the CT brain imaging, that will see if you're doing the CT brain imaging and then you see that it has been because of a subarachnoid hemorrhage. Okay, then nimesulide is the preferred antihypertensive. That is the only one indication in which we go with a very particular antihypertensive. Other than that, you can go with any antihypertensive. Okay, so then again in the TIA algorithm, as I was saying, then you go with the carotid imaging, then you try to, because see, if it's a TIA, just remember you need to find about the causes, right? Okay. So that is how it goes. So this was the TIA. Okay. Please look at this thing. I hope because I think it's the fonts are smaller. So okay. So for the suspected stroke, you need to classify it now. Okay, on the basis of whether it's 6 hours, it's an hyperacute stroke. If it is 6 to 24 hours, okay, or whether if it's more than 24 hours, that is a subacute stroke. Okay. So if it's a hyperacute stroke, see all of them, a patient, it comes to you with a stroke, okay, in Australia, even in EHA guidelines, whatever they say, because the how it happens over here is if someone, because the emergency medicine team, okay, the emergency medical services that reaches the patient, they analyze the patient, and then they directly call the hospital which is offering these stroke services, right? So see, this is called as, there's one term which is known as, bypass emergency, bypass ER, okay. It is used by AHA. What is bypass ER? Okay, because whenever the ENT medicine technicians, okay, whenever they inform the hospitals, okay, that we think that there's a patient of stroke with us, okay, so they what they would do, they would just straightly bypass the emergency room, okay. The doctor won't be, going with the vitals and everything. They will be straight away taking the patients to the CT scan, okay, because doing the CT scan is very, very important. Okay, there's time confined. Why it is very important? Because you need to locate the cause. Okay, you need to do it within 3 hours. Why? Because if you talk about the management, okay, the management is fibrinolytics or arterectomy. But there is one major contraindications of using fibrinolytic agents. Can someone tell me what is that? A very major contraindication. What are the two major types of stroke? If anyone can see, what are the two very major types of strokes? Okay, one is hemorrhagic and one is ischemic, right? So yes, exactly, Dr. Shubham. One is hemorrhagic and one is ischemic. Okay, so you cannot give the intrafibrinolytic agents in an hemorrhagic stroke. You can't. Okay, that is an yeah, exactly. You cannot give it in an hemorrhagic stroke. It's a major contraindication. That is exactly why you need to do the CT scan, right? Because you need to rule out. Why? Because see, most of the times you cannot see the emboli. Huh? Please take care. Whenever you're doing, you can. This is one another fact. It takes about 12 hours for CT scan to show you the that emboli in the stroke. Okay, then someone might ask, then why are we even bothering doing the CT scan? You are not doing the CT scan to localize the stroke. Okay, that is for the future management. You are doing the CT scan to rule out whether it's an hemorrhagic stroke or an ischemic stroke, because the management completely differs. Okay, and there is no room for error over here. Management completely differs if it's an hemorrhagic stroke or an ischemic stroke. Right? Because in hemorrhagic stroke, you need to go with an urgent cerebral decompression, the surgical indication, and while it's for the ischemic stroke, you go with the medical management. Okay, so that is what is included over here in CCT. You need to whether it's an intracranial hemorrhage or non-intracranial. That is what I say, an hemorrhagic stroke or an ischemic stroke, right? And that is what what is mentioned in this flowchart. Maybe you take a screenshot if you want. Okay, because okay. Now, as I said, in the TIA stroke, see over here it's 4.5 hours mentioned over here. This I have straight away taken from the RSEGP guidelines. Okay, so yeah, so that is in RSEGP they're mentioning 4.5 hours, but in the therapeutic guidelines they are mentioning 3 hours. Okay, so there is a little discrepancy over that, but don't worry, AMC won't confuse you with that. Okay, so over here they're saying that golden hours is 4.5 hours. So if it's within the 4.5 hours, you will directly straight away go with the thrombolysis. Okay, remember one fact about this, okay? They can give you two options, streptokinase or alteplase. Okay, what option would you go with if they say that preferred thrombolytic agent, whether it's streptokinase or alteplase? Because in India, in most of the government setups, we are using streptokinase. Yes, very right, Dr. Shubham. We're using streptokinase. But in Australia, remember, whenever you're preparing for Australia, you need to know about the certain group of population, which is ASTI, that is Aboriginal, Strait and Torres Islander people. Okay, and the streptokinase genetically it is contraindicated in this group of people because of rapid reaction in this ASTI group of people. In ASTI group of people, if someone wants to ask a question, they can maybe raise their hand. Please mute yourself. Okay. You prefer the agent over here also. It is alteplase, right? Alteplase or tenecteplase. We majorly go with the alteplase because tenecteplase is very costly. Okay, and after 24 hours, remember, after 24 hours, you start with the aspirin. You would never start aspirin within the 24 hours of starting thrombolytic agent, correct? Okay, and if it's more than 6 hours, then you go with something. You need to look at the history of atrial fibrillation, right? You need to see whether the atrial fibrillation is there or not. If there is, then you need to go with dual anticoagulant therapy. Does anyone knows what is DOAC? Okay, direct oral anticoagulants, right? And over here, what I was mentioning, we look at the Shadbeck's score. Okay, Shadbeck's score, that is what we look at. I know my handwriting is really bad. I'll try to, work at it. Okay, you need to look at the Shadbeck's score. Okay, I hope everyone knows that. It's one of the basic things. So in that one is atrial fibrillation. One A is for age, another A is for atrial fibrillation. Right? So if the score is just one, Shadbeck's score, if the score is just one or more than one, you need to go with the OAC. And that is exactly what I'm talking about here. It is dual anticoagulant therapy. Okay, you need to go with the clopidogrel. Okay, and all the associated drugs you need to go with, right? Okay, and if there is no history of atrial fibrillation, then you can simply go with one anticoagulant. Okay, over here you need to start with an antiplatelet therapy, right? Apixaban also you did. Someone is supposed to does it with an apixaban. Okay, and if it's more than 6 to 24 hours, there is now no role of the medical management over here. You just straight away go with the endovascular thrombectomy. So this was TIA. This is TIA mimics again, and from the RSEGP article. Okay, so can you see over here? These are all the mimics. So this is why low molecular weight heparin. Yes. Again, see, there is one concept over here. According to the very recent guidelines for the for the stroke, not only for stroke, even for the coronary stenosis or something like that. Also, even for the atrial fibrillation. Okay, there is an actually a debate whether you should go with LMWH, heparin, or DOAC, anticoagulant agent, right? Okay, but now, according to the recent guidelines, they say that it's better to prefer the dual oral anticoagulant agents and not heparin. You can also do with the heparin, okay? But when you're going with the LMWH, I know LMWH is not much of the side effects, and in most of the setups they're still using heparin, okay? Because again, it's easily available and cheaper, right, than anticoagulant agents. Yeah, but those are the options. Either you can go with heparin or DOACs, but if you have to choose, go with DOACs, right? And these are all the mimics, okay? For the TIA, which is migraine, partial seizures, vestibular disorders, intracranial lesions, okay, hypoglycemia. Hypoglycemia is one of the major cause, okay? Whenever a patient comes to you with, the patient is unconscious or drowsy or there's some drooping or something, always first do the FPS, okay, of GRBS, the random blood sugar, you have to do it, right? This is a very, very common clinical thing because hypoglycemia can very well cause the symptoms like stroke. Again, very important thing. A syncope can be there can be delirium, okay? There can be some, again, a very uncommon causes, which is motor neuron disease, myasthenia gravis, and also multiple sclerosis. We'll look at it in the upper motor or lower motor neuron disorders. I think the time may not allow us that. Okay, so these are all the TIA mimics. I think that is exactly what we were talking about in the algorithm, right? If it's not setting into your algorithm, then you need to rule out all these disorders, right? Okay. Another topic which I often find that people who are preparing for the exams, not just in AMC, for all the exams that's available, be it NEET, be it USMLE, be it PLEB, it's a difficult everywhere. Okay. I'll keep it little quick. Okay. I hope everyone knows the number of the cranial nerves. Yes, it's 1 to 12, all the cranial nerves, right? So I'll just take another click. Okay, let's do some little drawing. Okay, this is your midbrain. This is your pons, and this is your medulla, right? This constitutes towards your brain stem, correct? Okay, now talking about the cranial nerves, 1, 2, 3, 4 is in the midbrain. 5, 6, 7, 8. It is in the pons. 9, 10, 11, 12. That is in the medulla. Okay, this is for the remembering purpose. Huh? If you go with the core neuroanatomy, okay, the fifth cranial nerve, it has got what is the fifth cranial nerve? It is trigeminal nerve, right? So the trigeminal, it's a long nucleus of the trigeminal nerve. So it goes in pons and medulla both, right? So when we'll be discussing about the medullary symptoms, there would also be an involvement of the trigeminal nerve, right? There's also ninth annulum. It forms something known as nucleus ambiguous. Okay, nucleus of tractus solitarius. So these are all the the nucleuses which extends even in the pons as well as in the medulla. But for your remembering purpose and for your exam purpose, this is how you should remember. This is how I remember, and this helped me solve all the questions. Okay, so this is how it goes. Okay, now remember something known as rules of four. This I found it from first aid. Okay, first aid again, it's a very good book if you want to prepare for any exam for that matter. Okay, so for rules of four, what you need to remember is there are four midline structures and there are four side structures. Okay, when you talk about one part of the brain or one part, you take a cut section, be it in midbrain or pons or medulla, it would look something like this, right? So there is something. This is the what do you call it? The midline part, and this is your lateral part, right? Okay, please imagine with me. I know I'm not very good at drawing, but please imagine with me. Okay, so four midline structures and four side structures, right? So just remember when you talk about M for midline structure and M for motor tract, S for side structures, okay, and S for sensory. So motor and sensory. So all the motor nerves, they would be in the midline part, in the medial part, right? And all the sensory nerves, they would be in the lateral part, right? Okay. And along with that, along with the nerves, uh, I'm sorry, yeah, along with the motor and the sensory nerves, okay, you see something as medial longitudinal fasciculus, okay, medial lemniscus, motor cranial nuclei as discussed, and motor tract. What are those motor tracts? We'll come to that. And what are the side structures? The side structures is sensory nucleus, there is sympathetic nerve, there's sinus-cerebral, and there is spinothalamic nerves. Okay, this is something that you have to remember. Okay, so the midline structures, talking about these midline structures, the medial structures, okay, see, whenever there is a medial structural involvement, always the opposite side will be affected. And whenever the side structures are affected, the same side will be affected. So again, you can remember it by SS. Okay, I know that try to observe it with me because when we be discussing this in the lecture, I'll be doing it in very, very great detail. But as we are time constrained, we also have to go through the main topic, which is the career pathways. Okay, we need to keep it a little quick. Okay, so what are the medial structures? The motor tract. Okay, you need to know the tracts now. Okay, what are those tracts? Can someone name all of those? Okay, corticospinal tract, dorsal column tract, which is posterior column tract. Okay, then there is a spinothalamic, spinocerebral. These are all the tracts that you have to remember, right? Okay, so motor tract, which is the cortical spinal tract, which is responsible for the motor function, right? So if the motor tract, which is cortical spinal tract, if that is affected, can I say that it would also be affecting the opposite side of arm and leg? So it will be causing, in your question stem, we'll be coming to the question as well. In your question stem, you can see that there is a weakness of arm and leg on the opposite side. Correct. And if you talk about the sense, then the beta lemniscus, which is the posterior column. Now, posterior column that is responsible for the vibration and proprioception. Okay. Again, you need to, mug it up. I'm sorry to say that, but there is something with the neuro that you have to mug it up. Okay. So posterior column tract is responsible for vibration and the proprioception. The medial longitudinal fasciculus. Okay. If you know something known as INO, intranuclear ophthalmoplegia. Okay, does anyone know this term? If someone does, then I'll discuss it. Then I'll just, other than that, I'll just leave it. Does anyone know what is INO? Intranuclear ophthalmoplegia. What, in what disorder do you find that symptom? Okay, I guess not. Okay, so horizontal gaze, but yes, very good, Dr. Shuman. It is seen in the multiple sclerosis, very, very right. Okay, so over here, so in that multiple sclerosis, this MLF is affected. Okay, so what happens in the MLF? In that there is an horizontal gaze palsy. That is what has happens in the INO. That's true. Okay, but because it happens in the multiple sclerosis, okay, we call it the intranuclear ophthalmoplegia. So what happens in the same side? Okay, so if let's say the right side, my right MLF is affected. Okay, so that in that the medial function will be affected, and because the lateral rectus muscles, in the lateral rectus muscle, it is supplied by the opposite side. So my left eye, because my right is affected, my left eye, the lateral rectus muscle will be affected. So what happens over here is the same look. So if I try to look left enough, okay, if I try to look left, so what happens is the right eye would stay straight. Okay, if I'm trying to look left. Okay, this is a very deep topic. I cannot discuss it very quickly. If this is how it happens, it's an horizontal gaze palsy. Let's just remember till then. Okay, and then the motor cranial nerve nucleus. So just remember 3, 4, 6, 12. 3, 4, 6, 12, that is your motor nerve. Just cram it up. 3, 4, 6, 12, it's your motor nerve. Okay, and about this, what about the side structures now? Side structure is sympathetic. So when it comes to the sympathetic, there is one thing which we know call it as Horner's syndrome. Can someone quickly tell what are the symptoms of the Horner's syndrome? Okay. Meanwhile, I'll move forward. Can someone write it in the chat? What are the symptoms of the Horner's syndrome? Okay, one is sympathetic. Yes, one is anhidrosis. What about other three? There are 4 symptoms. Ptosis, yes, that's second. Ptosis, anhidrosis, one more. Meiosis, and one more. One more is the meaning. Yes, very good, guys. Okay, you can remember it by pain. The Horner syndrome symptoms. See, remember this one because they will be giving you in the clinical stem. Okay, they won't be saying to you that the sympathetic system is affected or there's some Horner syndrome we can see. They'll just simply tell you that in the right eye there is a ptosis, there is anhidrosis in the hands. Okay, E is for anophthalmos. Okay, as you have exophthalmos in the thyroid eye disorders in which the eye just pops out, you have anophthalmos in the Horner symptoms in which the eye moves inside. Okay, the simpler words. So that is the fourth thing. Okay, one is sympathetic, another is spinocerebral. That is the same ataxia in the arms and legs. Another is a spinothalamic. Spinothalamic is for responsible for pain and temperature. Remember, please. Okay, and that is the only why it is important to remember because spinothalamic, the opposite side is affected. Yeah, please remember this thing. In the medial structures, everywhere the opposite side is affected. Okay, but in the side structures, everywhere the same side is affected except spinothalamic nerves, in which the opposite side is affected in the pain and temperature. And remember, just sensory cranial nerve 5 it will be included in all the disorders. Okay, now just quickly look at the syndromes. Okay, for again, as I said, because we have time constraint, we're working with the time constraint. We need to look at just one, which is the most important question, the most common questions. Okay, I think if they ask 10 questions about this topic, 9 questions would be about the lateral medullary symptoms. So again, I'm not saying this on record, but if sometimes if you're confused, you cannot figure out what you cannot diagnose the brainstem disorder, go with the lateral medullary syndrome, okay? Because most of the time that is the answer. Because in AMC, as you know, because if you're going through the topics, in AMC, you have to attempt all the questions. You cannot skip the question, there's no negative marks given. So you have to attempt all the questions. Okay, so if I talk about the lateral medullary syndrome, so now can someone tell me, now you guys have to answer me because I've explained everything. Please tell me, I'll just draw the figure for you and you have to tell me, okay, that is midbrain, pons and medulla. This is medulla, right? This is medulla. And I am saying in medulla, in the lateral medullary syndrome, that is what we are discussing right now, okay? Lateral medullary syndrome, which is also known as Wallenberg syndrome, by the way. Okay, so I'm now saying to you that in the lateral medullary, so see, everything is in the name. Okay, the beauty is in the name, even though, but beauty is in the name. Okay, so you remember this. Medulla is affected, and I'm saying the lateral part is affected. Okay, the sideline structures are affected. Okay, so can you now tell me? Okay, I'll just even write the cranial nerves for you 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, so now tell me what structures would be affected one by one. Can someone just tell me quickly? Okay, I can also open this table for you. Okay, just read it and tell it to me. Okay, I'm saying that it is the medulla is affected and the sideline structures are affected. So now tell me, the table is in front of you. What structures would be affected and what can be the symptoms? Come on, guys, please, someone type. Keep it interactive. It is right in front of you. Okay, 5, 8, 9. Yes, very right. In ninth nerve, 11. Okay, cranial nerves. Apart from cranial nerves, we have four structures. One is cranial nerve. Other than that, what about other three? Sensory cranial nerves would be affected. Why? Because sideline structure, the sensory part. With a medial structure, it's a motor part. Okay, so if I was discussing about the medial medullary syndrome, then the motor nerve. So yes, very right, sympathetic. Okay, Dr. Shubham is the only one who seems to be the active. Other than that, okay. But yeah, because see, this you won't find in the official AMC resources. I'm telling you, I'm not bragging about my content, but you won't find this in the the proper AMC resources. Whatever you do, you won't find this because this is not the actual content. No, this is to make you remember. These are the tactics of how you should remember the topic, right? And that is exactly why I'm here for. Okay, you don't need me to tell you what is brainstem syndrome. You can just simply Google it up. You can just go through the your any other resources you can read about what is brainstem syndrome. I could have straight away gone through, what are the clinical features. See, it's right written over here. I could have simply just tell you in the lateral medullary syndrome, there's contralateral pain and temperature loss of the body, there's ipsilateral limb texture. None of you would have remembered it the next second. Okay, I can challenge you that. Okay, because I want you guys to remember this thing. So that is why I'm here to teach you, not to just make you memorize. Yes, very right. It's sympathetic. That second one. What are other things? One is spinocerebral and another is spinothalamic, right? So these four structures would be affected now. Okay, so if I'm saying to you, okay, let's write down those structures. If I'm saying that it's a lateral medullary syndrome now, okay, and the sideline structures are affected. First, very right, the sensory cranial nerve. So I'll say the cranial nerve fifth will be affected because fifth, as I said, it happens everywhere. The main is fifth cranial, no, 8 and 9 as well. Okay, that is one. Another is sympathetic. Okay, sympathetic cranial nerves. It's right written over here. The sympathetic nerves. Sorry, that will be affected, right? So that will be causing you the Horner's syndrome. What is happening? Okay. Okay. Sympathetic is affected. Then spinocerebral. All of these are same size or opposite side. All of these things. Sympathetic and the spinocerebral. What does sympathetic do? And what does spinocerebral do? Spinocerebral is important for the balance. So if there's some problem with it, it can cause ataxia. If it's in sympathetic nerve, it can cause Horner syndrome. So all of this would be same side or opposite side. Someone in the chat box. And another is spinothalamic. Yeah, very right. In spinothalamic. What about spinothalamic? Same or opposite? Same side or opposite side? What about spinothalamic? Could it still be affecting? What is spinothalamic first responsible for? Yes, Dr. Shreya, it is opposite. Yes, it's opposite. Okay, so what is spinothalamic responsible for? Yes, Tanushree. Yes, Dr. Tanushree. Spinothalamic is responsible for pain and temperature. Okay, so these four structures will be affected in your lateral medullary syndrome, right? So cranial nerve now 5 would be affected. So now see the magic. You can see. I'll just read out the clinical features, what happens in the lateral medullary symptoms, and you'll be like, okay, this is what we did. Right? Contralateral pain and temperature loss of the body. Yes. Why? Because spinal thalamic tract is affected, right? And that is contralateral. It was the key word, not same side, contralateral side, because they can also ask you in the AMC. They'll just say that which side. Okay, by the way, the lateral medullary syndrome, again, important thing, it is because of the occlusion of an artery called pica, which is posterior inferior cerebral artery. Okay, posterior inferior cerebral artery. Okay, because of that it happens. Right, so they'll just ask you which side is affected. They'll just say that there's a loss of pain and temperature in the left side of the body. Okay, you'll be tempted to think, okay, even the left side pica would be affected. No, there would be the right side would be affected, right? The right pica would be affected. Ipsilateral limb ataxia. Why? Why? Because spinocerebral tracts are affected. Spinocerebral tracts are affected. There will be an ipsilateral Horner syndrome. Why? Because sympathetic nerves are affected, right? Spinal nucleus of 5, as I said, trigeminal nucleus. It's a very long nucleus. It goes from pons and medulla both. So there will be pain and temperature loss of the face. Okay, but on the same side. Remember, on the same side. Okay, and there's also 8 and 9. What about 8 and 9 nucleus? What is cranial of 8? Oh, even I don't remember it by that. I need to use that mnemonic, OTA verb. Okay, 8 is auditory. Yeah. Okay, so it will be causing you to vertical nystagmus, okay, which will be away from the side of the lesion, right? And nucleus ambiguous, which I was mentioning to you. This is 8. Okay, see, look, we are going through all the nerves now. We did 5th, we did 8th, we are doing 9th and 10th now. And then we'll be doing, okay, 11 is not much affected. 11 it is, but won't see the symptoms. So the nucleus ambiguous, if it is there 9th and 10th, okay, there has been paralysis of the vocal cord, dysphagia, palatal droop. Why? Because it is 9th is dorsopharyngeal, right? So because of that will be happening. Nucleus of tractus solitarius, there will be a loss of taste on the same side of the trunk. Okay, that will be 7, 9, and 10. But do you need to remember all of these things? By just these things, you can just quickly figure it out. That's a lateral medullary syndrome. Okay, so there are all the symptoms. Okay, medial medullary, medial pontine, medial midbrain. Okay, lateral medullary, lateral pontine, and there's nothing called as the lateral midbrain. It is just a pontocerebral angle syndrome, which is acoustic neuron. Okay, so by this trick that I just taught you, there's 2 slides. Okay, one is this one, another is this. Right, you can solve all the questions. It is like math. Okay, do you have to remember math? You don't have to, right? So I hope this topic got simplified for you and I could help you in some way. Okay, so okay, I would love to. These are my favorite topics. Okay, so I would love to discuss this in detail, but we have to move forward. It's 6:50 already. Okay, just one question quickly. Okay, 59-year male. They can, okay, we don't have time, sorry. A 59-year male presented with a 6-year history of the sudden onset of diplopia, vertigo, nausea, vomiting, left-sided facial numbness, right-sided paresthesia below the trunk. Okay, past medical history of the ischemic stroke, hyperlipidemia, hypertension on the aspirin, and the ramipril, atorvastatin. Okay, he has positive cerebral signs and ipsilateral ptosis, right-sided loss of pain, temperature, and left-sided facial numbness. What is the clinical diagnosis? Okay, can someone tell me the answer and why? You can unmute yourself and say this. Okay, all of us are friends. So please don't take me as your teacher. I'm just that is why they say that I'm a tutor. Okay, I would be, maybe of your same age or younger than you guys. Okay, so we are just friends and we are just discussing a topic. Yes, please. Yes.
B.
B. Yeah, lateral medullary syndrome. Okay. Why left and why not right? And why
Right side
possible?
pain and temperature
Yes,
is
yes, yes, which is, yeah, so
contralateral.
opposite
Yeah.
spinal, contralateral. Yes, very, very nice. Okay. And the left side is facial numbness also, right? Because same side is sensory loss. Okay. Because of the cranial nerve 5, right? So because of this, see, go it in this pattern. Okay. First of all, see, this is no words. I'm just giving you my key. First of all, look at this side. Which side, left or right? Okay. In brainstem syndromes. I'm sorry. Left or right? Okay. After you're done with them, then you go with the whether it's a lateral or medial. Then at the end, you look at the structure. This is how you frame. Okay, so whenever you're solving the question, ask yourself these 3 questions. First, left or right? Okay, so because of this, we went that it is left. Okay, lateral or medial? Why? Because there is a sensory loss, there is a loss of pain and temperature. Okay, there is a cerebral sign, which is spinocerebral. There is also cerebral signs present over yours. There is an ipsilateral ptosis, which is again a sign of Horner syndrome. Okay, right-sided loss of pain and temperature sensation. Okay, which would be again just because of sympathetic. Okay, left-sided facial numbness, trigeminal nerve. So because of this, these are all the sideline features, the lateral features. So this is now lateral. Okay, is it midbrain, pons, or medulla? That you need to see. Can you see anything for the first two postcranial nerves? It's very simple. No, if you have to look at the structures, just look at the what cranial nerves are affected. Okay, you can see the fifth cranial nerve is affected. Okay, you can see that there's what the facial numbness is there, because in the pons and midbrain and pons, such facial numbness and everything won't be there, right? So because of that, you can see it is in medulla. So this is how it is in left lateral medullary syndrome, also known as Wallenberg syndrome. Okay, many times in the question they will also put it as just Wallenberg syndrome, because there is so many names of the syndromes. Right? There's one Wallenberg syndrome. There's then another one is this Frederick syndrome and all these things, right? So they just put the names in it. Okay, this symptom is just same. This is lateral medullary syndrome. Only they're asking you which artery is affected over here. I'll just highlight for you. In here, there's a nystagmus. There's a dictus hearing, which is again auditory nerve. Okay, 5, 8, 9, 10. Left-sided Horner syndrome, ipsilateral sensory loss of face, contralateral sensory defect of the limbs. Okay, everything is present. So I'm just right away saying to you, it is an lateral medullary syndrome. Okay, so which artery would be affected over here? It is the posterior inferior cerebral artery. So that is a question over here. Okay. I also wanted to go to the upper motor and lower motor neuron disorders, but it's okay. We'll just go to what do you guys want to do? Because I think we can either go serious or either do the odds kind. Okay. I collected a lot of topics because I was like, okay, let's discuss as much as we can. But I knew that we would be out of time, because once I start explaining, it will take time. Okay, Dr. Jibal wants to discuss upper motor and lower motor neuron, but I want it to be a little, variety of topic, because it's not a lecture. Don't worry, this is just a seminar. Okay, I'm just here to, to introduce myself to the peoples and the way how I'll teach. This is just, you can take it as a demo. Okay, so we'll just look at some top concepts of the obs and gynae. Yeah. Okay, one thing is, I've put in the two things. One is maternal infections, another is hypertension in pregnancy. I cannot stress more on the fact how important are these topics. Maternal infections, hypertension in pregnancy, diabetes in pregnancy. They ask a lot of questions on diabetes. Okay, just a minute. Okay, they ask a lot of questions on the diabetes, right? That is there. Okay, they don't ask, they don't go much in detail with the labor, yeah, as they do in meat. They don't ask a lot of questions on the labor, I guess. I know they don't ask, okay, but they want you to know a lot of clinical stuff, right? Because the AMC exam is for you to work over there at the internal level, or at max as a junior medical officer, right? Okay, when I've been discussing the career pathways, I'll also be talking about the job offer that I've received, okay, and then we'll go through it. But they want you to work at the very basic levels. Okay, so you're not supposed to take very, high-fi clinical decisions. Okay, jumping right to the topic in the maternal infections, we'll be going at some, okay, as I said, this is from the therapeutic guidelines. This is statement I've taken from the therapeutic guidelines. First is chorioamnionitis. Okay, very, very important. Chorioamnionitis, it is nothing but, it is the infection of maybe say of the fetal membranes, or the decidua, of the amniotic fluid, of the placenta, of the fetus, anything. It can be of the chorion or it can be of the amnion. If you are clear with your concepts of the embryology, you know what is chorion and what is amnion. Okay, I want to go into the details with that. Okay, so if any of the structure that I just mentioned, if it's getting affected with the Streptococcus agalactiae, that is group B Streptococcus, GBS bacteria, I mean to say, or Enterobacteriaceae family, or any Enterococcus bacterium, we call it as a chorioamnionitis. Not just with that, they'll be giving you the clinical symptoms. Yes, okay. So what would be? One would be fever. Okay, fever and the ruptured membranes. How do you know it's a ruptured membrane? This is a very clinical question. Huh? How do you know that the membranes are ruptured? Very simple. How do you know that whether the membranes are ruptured or not in a patient? Because you won't be just straight away doing the pervaginal or perspeculum examination, right? You cannot do that. That is also like there are certain indications of doing the pervaginal report. Gush of fluid, yes, very good. Gush of fluid is there. Okay, so if a patient complains to you, right, in the allow me to speak something in Hindi, that they say the pani gir raha hai. Okay, the water broke in the common learns, okay, common layman language. They say the water broke. So that you know that the membrane is not ruptured. So if the membrane is not ruptured, I hope you're clear with the concepts of the PROM and the PPROM. Okay. In the PROM and the PPROM, the most common in I can also take the liberty to say the only infection that happens at the PRO and the PPROM is chorioamnionitis. Okay, so that is why it makes it a very important topic. Whereas PPROM or the PROM, it is a pre-rupture, a preterm rupture, right? If it's in a preterm, then it's a PROM. If it is a premature, okay, the labor has not started, but you can see the gush of blood, then it's a premature rupture of memories. Okay, so if those things happens, then you can say it is they're prone to, chorioamnionitis. If there's a uterine tenderness, the patient complains that there's a lot of pain. Pain that is not labor pain. You must be able to even differentiate between the pain and the labor pain. And there's a purulent amniotic fluid. You can see the fluid and you can see it's green in color, right? It very well shows that the fluid is infected now. Okay, so if any of these features are affected, then you can say it is in chorioamnionitis. Okay, so what is the empirical therapy? See, if it's in PROM, PPROM, okay, whenever, like, in the future, I don't know, whenever if I discuss this topic, the mentioning that, what all antibiotics use it and in the when. Okay, and in the PRM, the PPRM, what are some very important? One is antibiotic you must administer. One is corticosteroids you must administer, the PRM, PPRM for the fetal and maturity. Okay, these two are the most important things. And the tocolytic agents, but only under certain indications. So when the PRM or the PPRM comes, three things must come in the mind. One is an antibiotic that we'll be just discussing. Another is the corticosteroids, and third is the tocolytic agents. Tocolytic agents, you can only be using it, okay, when you are referring the patient for somewhere, okay, and you cannot let the baby deliver somewhere. You need to refer the patient to the tertiary healthcare center, and you want to delay the delivery of the fetus, okay, then only you can use the tocolytic agents. Let's not have flight of ideas, or then I think we'll be speaking till tomorrow morning. Okay, but you require surgical prophylaxis. Okay, so what are all the antibiotics that you must require over here? Okay, one is gentamicin, very important. So just remember gentamicin. I've already mentioned it for you guys. Just remember gentamicin plus amoxicillin or ampicillin. Okay, so if it's a chorioamnionitis, direct questions, please guys, mind well. Okay, don't think that AMC is some out of the world exam. It is like any exam that I can talk about the people from the Indian subcontinent, also for the people anywhere. It's like any exam that you've taken, it's nothing different. They will be even asking you straight away questions. Okay, which antibiotic need to be using? The only difference between the Indian setup exams and this exams is that first they will ask you to diagnose the condition. Okay, they won't be straight away telling you it's a chorioamnionitis. That is why I took a great time to explain in detail that how do you diagnose the chorioamnionitis. Okay, so once you know it, then you know that what antibiotics you must administer. So just for now, just remember gentamicin and amoxicillin and ampicillin. Everywhere you go, see in all the indications of the antibiotics for the AMC, one thing will always be there. That there is what if there is a penicillin prophylaxis, right? So the antibiotic changes. Whether there's an hypersensitivity to the penicillin. So this amoxicillin and ampicillin, I hope you know that they are from the beta-lactam group of the antibiotics. So they are from the penicillin tribe. So you need to change it. Okay, so then you'll be going into the cefazolin and the metronidazole. Okay, cefazolin group of antibiotics. What is the group of antibiotics of the metronidazole? Someone can put it in the chat box. It's okay. Okay, remember for the pharmacos, you need to remember the group of antibiotics. Yes. Okay, so for now, for saving time, just remember gentamicin plus amoxicillin or ampicillin. Okay, that is what you give it for the chorioamnionitis. Okay. I don't think I want to discuss this right now. GBS infections. Yes, GBS is important. There's two infections I want to. Okay, what is GBS? Groupie streptococci, right? Okay, so it is a very important. Okay, can someone tell me that if it's in UTI? Okay, let's consider two scenarios. In the UTI, when would you start the empirical therapy or the antibiotic therapy? When you'd be starting it in the normal adult men or women, but the normal level, who's not pregnant, non-pregnant person and in the pregnant person. Is there any difference in the in the management algorithm? Quickly, if someone can tell it me in just 10-15 seconds, or that's I'll tell it. Doesn't even know. It's a very clinical point. Okay. When do I start the antibiotic in a pregnant person? When do I start the antibiotic in a non-pregnant person? Okay. Can someone tell me? Because this is UTI again, a very favorite topic, if I can say. Very UTI, cystitis, okay, urethritis, all of this are the very important questions. Does it even know? Okay, so in the UTI, okay, there is one term which is known as asymptomatic bacteriuria. So how does the patient of UTI present? Okay, this doesn't even know about this. It's a very common symptom. If you're doing your internship, if you've done your internship, if you'll be in any clinical setup. UTI is the most very common thing which happens. How does any patient with UTI present to you? Anyone? Anyone know the triad of the UTI? Maybe just something, just one. It can be as simple as a fever. Fever is there, no? Yeah, painful urination. Yes, yes, yes,
Dysuria.
yes, yes. Dysuria, very good. Yeah, but dysuria most of the times it's a microbiological diagnosis, right? The patient won't tell to you that I'm having dysuria. I'm just when you say the clinical symptoms, it's in the patient's language. Yes, very good, everyone. There is a burning maturation, so that will be most common complaint. And most of the time, the patients are dehydrated; they don't have UTI at all. Okay, that is where they have the burning maturation. So the one is a fever. Another would be, the painful maturation. Okay, and the dysuria, yeah, you can use the term, but actually the dysuria made people say that when there is a pus, then you can again call it as a dysuria. Okay. So this will be a presenting. Okay, so when do I start? Would I straight away, if the patient comes to me with these things, would I straight away start with the antibiotics? Would I straight away start with the norfloxacin, or cefazolin, okay, or nitrofurantoin, which are the antibiotics of choice in the UTI? Would I be straight away starting with that? Okay. Yeah, no, we won't, right? Because there's a term. Yes, Dr. Shubha, we won't be starting with it because first of all, you need to do something as urinarium. Okay, you need to do the routine microscopy of the patient. Okay, and if it's a urinary, then you have to straight away. If it's in bacteria, okay, then you see that there is a bacteria present over here. Okay, so you'll also only start antibiotics when there is a symptomatic bacteria. Remember, if it's an asymptomatic bacteria, because first of all, you don't routinely do urinary. Okay, if there's a symptoms are present and then you find okay that bacteria is present, only in symptomatic bacteria you will start with the antibiotics. But that is a catch in the pregnant patient. There's a catch is that even because see, we routinely do urinarium in first trimester as well as in the third trimester as a part of the routine investigations. If you find bacteria over there, you'll start with the antibiotics. We don't take any chances. Even if the patient is not having any symptoms, even if the asymptomatic bacteria, which brings me to this point, okay, that in urinary tract infections, even in the asymptomatic bacteria, you will start with the antibiotics. Okay, another cystitis, pyelonephritis, all of those are just same. Only the anatomical part which gets affected that differs. Other than that, the symptoms and everything, the management remains the same. Okay, antibiotic of choice of the UTI in pregnancy. Anyone knows? Antibiotic of choice of UTI in pregnancy. Very important EMC question. Very important. If anyone knows, then just drop it in the chat box, and meanwhile, I'll just move forward. Okay. Okay. No. You don't use ceftriaxone actually commonly. Ceftriaxone we cannot. Cephalosporins we don't use it in the UTI. Ciprofloxacin, no, not commonly used. The group is right, but you don't use ciprofloxacin. You use norfloxacin. Yeah, this is how this may be a shock to the Indian setup because we use norflox so commonly. Okay, I don't have time right now, and I need to find those guidelines as well. We use norfloxacin so commonly according to the Australian guidelines, even the American guidelines and the proper guidelines. Norfloxacin should is like the last line management. Okay, you never start with the norfloxacin. Okay, you start with cephalexin. Okay, cephalexin, which is a cephalosporin, is an antibiotic of choice of a UTI in pregnancy. Okay, you can also use nitrofurantoin, but nitrofurantoin, can we give it in the pregnant patient? Can we give nitrofurantoin in the pregnant patient? We can't. It's contraindicated. Okay, we can't do it. Okay, so yes, Dr. Tanushi, we can't. Okay, so we are going. See, this is from the South Australian guidelines. So whenever you're doing the obstetrics, I urge you, I would request you to please go through essay guidelines. You just simply type essay guidelines in Google. You will find everything in the world that is to know about the obstetrics. Okay, and essay guidelines, I think it is the most efficient guide. So we'll also include it in the notes. Okay, because if you're joining the academy, that will be a good idea. But then you don't have to go through all these efforts because essay guidelines is very detailed. Huh? It will take a lot of time. That's very important. Okay, so if you talk about the hypertension in the pregnancy, okay, we use certain terms, which is gestational hypertension. We use preeclampsia, we use pregnancy-induced hypertension, we use chronic hypertension. Okay, these are all present over here. Okay, like if there's a pregnancy-induced hypertension, there's two things, no? One is gestational hypertension, pregnancy-induced hypertension. Another is chronic hypertension. Okay, what is the difference between the two? It's very simple. Can someone quickly tell me? Okay, yeah. chronic hypertension, CHR means it's not because of pregnancy. Yes. Right. So if the hypertension, if the hyper, yes, pehle se. If the hypertension is present before 20 weeks, okay, then you see it's a chronic hypertension. If it's a pregnancy-induced hypertension or a gestational hypertension, it happens after 20 weeks. Cool. Okay. If it's a preeclampsia, okay, if it's a preeclampsia, when you say there are two definitions to call it as a preeclampsia, okay, we'll come to that. Okay. If the BP, where is it given? I think I've included that. I hope it is there in the presentation that I've made. Okay, maybe not. Okay, if it's a preeclampsia, there's one thing is if the BP is more than 170 by 100, we straight away call it preeclampsia, right? Or if the BP is more than 140 by 90 plus this symptoms, all of this, which I've mentioned over here. Okay. This two definitions of preeclampsia that you must remember. If the BP is straight away more than 170, 100, that's a preeclampsia. Start your management protocol of the preeclampsia. We'll come to that. If its BP is more than 140, 90, and there is a kidney impairment. How do you see a kidney impairment? Are you guys aware of dipstick examination that we so commonly do it in our wards in India? Yeah, protein. Yes, exactly. You'll take the cap of the, any pint. You'll just take the cap. You'll ask the lady to just maturate it, and then you'll dip it in the dipstick to see if there is a proteinuria or not. Okay, so by this you'll see the kidney impairment. You'll see the thrombocytopenia. You look at the blood reports whether there's a thrombocytopenia or not. You look at the AST-LG. You look at the liver profile. You will see there's a headache. Headache is an alarming feature. Alarming feature. Very risky. Okay. You look at the epigastric tenderness, you will look at the fetal compromise. That you can do it by the CTG. CTG is cardiac topography. Okay. So if any of these features are present, okay, there's also one is HELP syndrome. Again, a little another topic. What is HELP syndrome? Okay. One is hemolysis, elevated liver enzyme, and low platelet. That is what HELP syndrome. There you can find all these features in this as well. Okay. Hemolysis, this is there. Low hemoglobin will be there, elevated liver enzyme, that is AST-ALT, or low platelets. Okay, if any of these features are present along with a more than BP of 140 to 90, you'll call it as a preeclampsia. Okay, the grading over here, it's given in the essay guidelines. There's mild preeclampsia or the severe preeclampsia. And in the severe preeclampsia, you need all these features. Okay, right. So there's an hypertensive management, everything is given. I think we should now go to the career pathways where the drugs and everything is I've given. See, just quickly look at the table if you want to. Methyl dopamine and nifedipine are the most commonly one used in the antihypertensive medications in the pregnancy. You can find the dose, you can find the practice points and everything over here. If there is an acute BP lowering, you need to lower the BP acutely. You must have to do it with the nifedipine, with the labetalol, with the hydrolazine. Okay. There's so many things you need to look at the dosage, and this flowchart is very important. But I think the time won't allow us today to do that. Okay. Yes, so let's come to, this was all about the educational part of the seminar. Now let's come to the career pathways. For what I think most of the people are here for. So many, some people left. I don't hope they didn't get bored. Okay, so career pathways. Okay, I'll go through the career pathways of the AMC, which is a very commonly question people ask. How do you start with the AMC? Yeah. Okay, so there's in the AMC, but there is three pathways available. Okay, there's standard pathway, there is a competent authority pathway, and then there is a specialist pathway. Right? Is anyone over here who has already done the post graduation? You can just raise your hand. Does Zoom have that feature or Google Meet has the feature? Yeah, sorry. Yeah, okay. Is anyone over here who has done their post graduation after MBBS from any part of the country? So that I can know. So then I want to discuss the competent authority pathway. If there is, then I will. Okay, then I'll just straight away explain the standard pathway, which is what I'm going through right now. Okay, so standard pathway, okay, that is with the, it's as simple as that. Standard pathway is for anyone who has done an MBBS from a medical college, which is recognized by the world directly of the medical schools. Okay, you can just directly go to the website and just type the name of your medical college in that, and you'll just know. Okay, so if you've done the MBBS from recognized by the school, okay, then you are eligible to sit for the AMC examination, and then you can take AMC CAT and CPO examinations. Okay, this is the standard pathway. Another is the workplace-based assessment. Okay, that is by the examination and like the CAT plus the workplace-based assessments over here. That you don't have to give the AMC MCQ. So when the doctor of Mujam, is it true that after apply we can directly apply the computer project without UK experience? I don't think so. So I'm sure about this, but I think today only. Are you referring to the Dr. Rizwan Precious video? I think he only updated about it, right? I think I've mentioned it over here. I'll go through it. I'll have the table with me. Okay, I'll just give you directly. This is directly from, see, yesterday only. Yesterday, the day before, I have taken this. I've taken the clear screenshots from the AMC website. I'm just telling you as straight it is. Okay, I went to the AMC website. Okay, the MB website, that is Medical Board of Australia website. I have taken screenshots from that. Okay, I don't see it anywhere. For you to be doing it from the UK after play, you need to have successful completion of the foundation year work in the United Kingdom, or you should have done the 12 months of the supervised training in the United Kingdom. Only after that you are eligible to directly go with the competent authority pathway. Other than that, not just with PLABs. Okay, so I'm telling you, which is the latest update from the MB. Okay, I don't know why Dr. Rosenkrantz maybe said that. Maybe I'll just also update it and let you guys know that, but it's not on the website. That is what I have to tell you. Okay, I'm not contesting against that person. Okay, he has got a way more experience than I do in this field, but it is not on the website. That I can say for sure, because I've done a good amount of research on this, and I don't think so. Okay, so as I was saying, for the standard pathway, you do go with the AMC CAT examination. Okay, so over here it's given as such, simple as that. You just need to pass your MCQ examination. Then you need to pass your AMC clinical examination. You get your employment offer. Then you're eligible to work, and then you apply for MBA for the provisional registration. There's three type of registration. I'll come to it. Okay, so after you are done with the MCQ examination, as I had told you, what I'm good. So actually, I took my MCQ just a minute. I took my MCQ examination, and right now I've got the job offer from the two GP clinics, general practice clinics from the North South Wales. Okay, so I'm very much interested in the general practice as well. I'm all up for it. So I got it after AMC MCQ exam. Okay. Okay, so you can take the GP pathway as well. You can, sir. How many MCQs in the AMC CAT? 200 MCQs. Okay, 200 MCQs is that 200 MCQ questions, and you get. I'm sorry, it's 150 questions. I'm sorry, it's 150 questions. Yeah. Oh my God, it's just been 2 months and I'm getting confused. I'm sorry. Okay. So and for that you get 210 minutes for 150 questions. I'm so sorry. Wow, it's embarrassing. Okay. So you take the MCQ exam. After that, you take the clinical exam. Then you apply for the jobs. Then you apply for the registration. This is as simple as a standard path you can get. Okay. Or other than that, after you give the MCQ, you can secure an employment offer. The pathway which I am going through right now, and I'm figuring it out. I've got an employment offer letter. Okay. So after that, I need to apply to MBA for limited registration. Okay. I'll be applying for the limited registration, I think, after 1 month, next month or something. Okay. Then you complete the 12 months of the supervised practice. Okay. So if you're going through, there's levels of supervision. There's one thing known as level 1 supervision. What do you mean by level 1 supervision? The offer letter that I've got, they've mentioned that I'll be working in the level 1 supervision. Right. So level 1 supervision means it's 1-to-1. I cannot see any patients on my own. I have to clear all the patients by my supervisor. Right. So you need to have completed 12 months of the supervised practice. That is level 1 supervision. Okay. And during the period of the supervised testing, you can either pass the AMC clinical examination or you complete your workplace-based assessment and then you receive the AMC certificate. Okay. So that is in another pathway. See, AMC, I think, it's very, very customizable. Now you go to the shopping mall, you go for shopping with the clothes, it's very customizable, right? You choose this, you choose that. Okay. Contrary to UK and US, there is not one straight path. Like if you talk about the US, there's just USMLEs, right? You just need to clear your USMLE step 1, step 2, apply to the NRMP, that is National Residency Matching Program, get into the residency, and then it's as simple as that. It's very straight pathway. There is no variations in it. Same applies to the UK as well. You clear your PLABs, get into a job. Okay, and is job experience required to get job after AMC department? Yes, you most certainly do. You need to be PGY2 plus. Okay, so I think as I have mentioned this, right? I'm PGY2 plus. I've got a 1 year of the internship experience. That again, that internship should be from an hospital which is recognized by the world directly or the medical colleges. Okay, the internship from that. Okay, and I did my internship from Gujarat. Okay, from Ahmedabad. Okay, so internship from that, And other than that, you need a 1 year of the working experience. I've got a 1 year of working experience working as a resident medical officer in a sub-district hospital. Okay. So I think you require a minimum of 2 years of working experience. Other than that, I don't think you stand a chance. Okay, so that was this there. So medical registration, as I was talking about, there's three types of the registration. Are 3 to 4 months gap bad between MO jobs to get job in US? See, gaps are not bad as long as you can explain it, right? I think if you've got a gap in your CV for more than 3 months, I think it can be a red flag. Okay, you can only see, this is written nowhere. This is not a rule or something, but this is what I've got to know from so many people who's working over there. Okay, maximum that you can go with is 3 months of gap, right? Okay, and if it's more than that, then you need to explain it. You need to have a very good explanation. They would be asking you this in the interview. Yeah, because I finished my internship in 2023 in the month of March, sorry, in the month of April. Okay, and then I got into my first job as a junior resident. That was 2 months in the June. Okay, so they did ask me in the interview that what did you do for April, May, and for the June, because I joined it in the last month. So what did you do for this 3 months? Okay, so I told them that I was, preparing for the exams, this and that. So you need to explain it. Till 3 months is okay. More than 3 months, you need to explain that. Okay, why is that? Okay, so talking about the registration, one is limited registration, one is provisional registration, another is general registration. Okay, after your AMC MCQ exam, okay, if you want to work, okay, as like I do and what I'm doing, I need to apply for the limited registration, right? Okay, so IMGs must pass the AMC CAT MCQ examination and then can apply for the board for the limited registration. Okay, I'm sorry, what is Dr. Dana say? I'm a graduate from Philippines. I did internship, which is a part of my final year. Med school requirement for me for to graduate. Do I need to do postgraduate internship for applying for jobs in Australia? If yes, can I do internship in any hospitals in India? I think you need to clear the FMG exam, right? I'm assuming that you're from India. You need to clear FMG exam, no? You need to clear your FMG exam first, which will be substituted by next, is what they are saying. Okay, no one knows what next will be. You need to clear FMG exam. After you clear your FMG examination, then you need to do an internship from an hospital in India, because from Philippines, I don't think it's recognized. Doing internship in Philippines, I'm not very sure about that. I would request you to do that, because I know many people who's done their MBBS from Philippines, from China, from Ukraine, from Russia, and all of those they did clear the FMG exam, and then they did the internship in India for 1 year. Okay, and then we are in some certain jobs, and then they are looking for jobs in Australia right now. Doing internship in Australia, it's not a child's play. It's very difficult. Okay. Dr. Shpan, so they do count the internship which we do after clearing FMG? Yeah, yes, they do. They most certainly do. Yes, yes. I am FMG post internship also in Gujarat. Is private corporate hospital work experience counts, or does it have to be government? No, of course it counts. Of course it must. I'm working in a government hospital. It works. Work experience holds true everywhere, and does not need to be government. Okay. Sir, after 1 year CRI in India, AIMS MCQ pass, what should I need to do to get in Australia? Can I give AMC MCQ during CRI? Okay, compulsory rotatory internship. That is what you mean. Okay. After 1 year in India, yes, you can. No, you can't. I'm so sorry. Okay, you're saying during CRRI. During CRRI, during internship, you can't, because see, okay, I think this was not in my this thing, but I'll explain it to you. Please look into the screen. Okay, so what is the pathway, If you want to take AMC, okay, let's see that one of you, Dr. Shubham, wants to take AMC CAT exam. What does he need to do? Okay, first of all, he needs to do his EPIC verification. Okay, I'll come to the questions later. First, let me finish this. First, you need to do the EPIC verification. Like, you need to go directly to the website of the EPIC. You need to get verified over here. You need to post, upload your certificates and everything. And they do ask for your registration number. They do ask for your degree certificate, for your university degree, right? And you cannot get your university degree. I'm talking about India, yeah, because this is for the Indian side. You cannot get your university degree until you have finished your CRI, the so-called. Until you finish your internship, you cannot get your university degree. So you need to final degree diploma. That is what they say it in EPIC verification. Okay, final degree diploma. So you need to upload your final degree diploma Okay, in the Epic, then after this, you will get the Epic ID. Okay, that Epic ID, then you need to make AMC portfolio. Okay, you need to go with the AMC portfolio. Yeah. In that AMC portfolio, whenever you are making AMC portfolio is nothing, you're just registering with AMC, you're just making your account in the AMC portal. Okay, so but over here, you need to put your Epic ID. Yeah. And after you're done with the AMC portfolio, then you are eligible to now book for AMC. AMC MCQ. Okay, three things you need to do. Okay, Epic, AMC portfolio, then go with the AMC examination. Right. So this you cannot do it without having a final degree diploma, and you cannot have your final degree diploma until you have finished your internship. I think there are a few questions. Do they ask for salary statement to confirm they have done job or not? No, I don't think so. They didn't ask from me. They would require not the salary statement, they would require the experience certificate, right, from your institute. Yes, they'll ask that. So do they do count the internship which we do after? Okay, that is just. So I'm also an MBBS graduate from the Philippines, currently studying, but I haven't written FMG yet, but planning to temporarily go to private hospital for practice. And I still get an internship in Australia. Private hospital where? In India or in Philippines? After MCQ pass, will I get into Australia for GMO jobs, or is it tough about WB after Sierra Leone and India? So, it is difficult, yeah. Getting into GMO jobs is difficult, yeah. I must say, huh? It is difficult. If you see there are many campaigns available, there's one is NSW campaign, which I applied to. See, state campaigns run. One is NSW campaigns. Right now, Queensland campaign is running. Okay, but it is difficult to get into those jobs. I won't disagree to that. Yes, it is. There is 150 MCQ, but pass score is 250. What that means? Still confused. Oh my. I don't think that was into the scope of this today's seminar. But since you've asked, I'll just tell you in brief. What is the complete name of this exam? It is AMC MCQ CAT. What is CAT over here? Does anyone know? Because since you guys are planning to take AMC exam, what is CAT over here? CAT. It is computer adaptive test. Yes, computer adaptive test. So you don't know. No one knows this. Okay. There is 150 questions that you need to, because see, what it is it's computer. Computer is taking your exam. Okay, so what it happens, what they say, see, there are just rumors, huh? No one knows this. Because what they say is it's question number one. Okay, question number one is, let's say, about preeclampsia. Okay, and you marked it correctly. Okay, so they would say that, okay, this difficulty level of this question, the candidate is clear, so the next question would be more difficult than that in the previous question. Okay, so if you mark the second question, which is more difficult, correctly, you will be graded more marks. Right? So there is not one specific score attached with one question. Okay, computer decides that how much should I be graded for this question, right? They also say that out of 150 questions, 15 to 20 questions are just mock questions. Okay, it doesn't matter what you answer to those. They just want to do the research. Okay, that what are the candidates applying? What are the candidates answering to these questions? They just want to know the trends. Okay, so those 15, 20 questions, there's no score for that. It doesn't matter whatever you answer for that, right? For another question, some questions will be easier, so you'll be graded less marks for them. Some questions will be difficult, you'll be graded more marks for that. Only computer decides this. No one knows this, right? So it's very difficult thing to right? That how is it going to? Even I had the same question, but yeah, that is how it works. Can you elaborate about your CV? Do you have research papers? Yes, I did. I had two. I have one research paper. According to Duke Collins, there are no pilot questions in the exams. Yes, can be. That's why I said no. That's what they said. Even before they weren't so sure about about the pilot questions. Okay. So I'm saying that's what I'm saying. See, no one knows about these things. And how do they conduct the exams? No one. Trust me, no one. All of those things which you get. See, another thing that I'll just say, since you are with me, one of the things I'll say, there is this one very, very widespread rumors about the months that you take your AMC MCQ in. Okay. Because AMC conducts the MCQ exam to February to November, right? In the December and January they don't. Okay, so what they say is that the November is the easiest month. There is the greatest ratio of the passing is in November. There's no data available. No one knows. They say that the February and the June months, they are the most difficult months to clear your exams. I took it in June, I passed. Okay. Some of my friends, they took it in February, they passed. Okay, and some of the people that I was preparing for my exam with, okay, they postponed their exams. They postponed their exams to July. They postponed their exams to August. And what was the reason? Because they say that people have this rumor that the June exam is very difficult. Okay, there is lots and lots of rumors that is attached with it. Some say that the morning slot is easier. Some say the evening slot is easier. Some say that because the AMC conducts the exams from Monday to Saturday for the whole week every month, right? So some say that if you take the exam the Thursday, Friday, Saturday, you have more chances of passing the exams. If you take it in the Monday, Tuesday, you have lesser chances of passing the exams. So many rules, so many rules are attached to this exam, but there's no proof for any of that. If there's anything that matters, it's just your preparation. Okay, I won't say that June was easy. Okay, June was very difficult exam. If some of you are preparing for the AMC and if you have done your June 2024 recalls, the exam that I gave, okay, it was difficult. It was difficult for sure, but so was other months, right? So I cannot say that. Yeah, okay. So those are just rumors. I cannot confirm on that. Okay, so we are talking about the registration. Yeah, so limited registration. You get it for the supervised practice, which I did. I've got the job offer letter for the level 1 supervision, so I'll be applying for the limited registration. AMC2 being conducted only in Australia member. Yeah, that is true. I don't think that's rumor because they're shifting from AMC to first. Let's just focus on AMC MCQ. Clear your AMC MCQ, then we'll talk about this. But yes, those are true actually. Like till because of the COVID exam, they for the AMC clinical exam, they went more with the online examination and not the in-person examination. That was because of the COVID. But since the COVID has subsided now, from the next year, they are saying that they will be going more with the in-person examination. MBBS graduate for Philippines. I'm taking MCQ in November, doctor, but I haven't written FMG yet, sir. Just planning to work in private in India. Could you tell me if there is a possibility of getting an internship in Australia? Is your hospital recognized by the World Directory? Have you checked it? If it is, then yes. We can do online also, yeah? Yeah, you can. Sir, I just want to get in. You can, but I think they will be reducing the slots for the online. Most of the slots they'll be giving it for November. As I said, guys, focus. Right now, your target should be MCQ and not clinical. Sir, I just want to get into Australia so fast, sir. I may sound silly, sir, but my girlfriend is there. Oh, wow. After AMC, what way I get there soon, sir? Just wanted to get into Australia soon. All I have is CRR. I want to get India. Please help me. Ask your girlfriend to get into India for a while. Because getting into Australia is not that easy. I'm afraid, my friend. Okay, it will take a good amount of years. And after just internship, I think it's very difficult, man. Because I've known people who've got like 4 years, 5 years of postgraduate experience who've done that PG also. Okay, one of my seniors, he's done PG in general medicine. He's MD general medicine, and still he's finding one of the person he's done MSc ENT. Okay, in otorhinolaryngology. Still he's facing difficulties in getting the jobs over there. You understand this, right? So it's not that easy. Okay. So other was the provisional registration. The provisional registration, you need to clear the academic and the clinical examination. Okay. Did you join any coaching? I just joined for it wasn't a coaching per se because when I took I didn't have much of the options to be very honest. Right. I was thinking to join some, but then I got the material and everything from that. Okay, and hopefully I did pass. We can do online also. Check you are applying through. Provisional registration is after you have taken the clinical examination, but you don't have work experience, then you go with the provisional. The general registration is you cleared AMC1 plus AMC2 plus 12 months of the supervised practice. That is minimum for 47 weeks of full-time service. Then you can get the general registration. Then after the general registration, you are a free bull. Okay, you can do whatever you want in Australia. Okay, you can go with the GP, you can go and apply for the residencies and everything. For the competent authority pathway, I think one person did ask, sir, what made you go ahead with the Australia compared to the other options out there? Just, yeah. So many people ask me this question. You get into my DM. I think I can share my contact number after that. We'll talk about it. Okay, eligible for the competent authority pathway. I think we are at the end of the seminar. For competent authority pathway, I'll just quickly go. If it's in UK, you need to have cleared your both the PLAB exams, and then you need to have done the foundation year. Right, so 1 year of work experience. Okay, I'll just finish it, and then guys, can you please ask me the questions after I finish the seminar? Okay, I'll be because I think some of the questions are getting repeated. Okay, so I'll just take all of them together. Okay, so UK is there. If you've taken USMLE, okay, so if you have completed step 1, step 2, and step 3, and you have done 2 years of graduate medical education within the residency program, which is accredited by the the graduate medical education, then you are eligible to sit in the competent RP pathway, right? So I'm just discussing US and UK. There's also Canada. There's also Ireland and all, right? So this is that. Okay, competent authority pathway. I think I mentioned everything about it. Specialist. I don't think, because I asked this question, I don't think anyone is anyone over here a specialist. Okay, so I won't go through it. Okay, so I'll just quickly go through the questions. If you have any questions, just quickly drop it in the chat box. Then I'll just hand it over to Asma. Uh, Hello, sir. I graduated from the Philippines. So you're replying in that. Okay. Okay, you're talking amongst yourselves. Okay, no further questions? Yeah? I don't think there's any new questions over here now. I'll just wait for a couple of minutes. If you have any other questions, please move forward. Can you talk about this course? Okay, yeah. This is Indian Med Exam Expert. If you take the regular course, you'll get an access to the notes. You'll get access to all the lectures. Okay, lectures, of course, right? We'll be taking the lectures in good detail. You'll get an access to the notes. You'll get the access to the question banks, okay, which is very detailed, okay, which includes all the major questions banks that's out there. You'll get the mock tests, mock exams. Okay, and as said, one can call AMC counselor for details. Yeah, please contact them. Please drop them the message. How long is the limited license valid? Yeah, that is the best thing about Australia. Okay, see about the limited registration. See, there's one thing. Okay, so as I said, that there's a level 1 supervision that you need to work through. So it's minimum 3 months, maximum 12 months. Okay, so after 3 months, see, they do the reviews every 3 months. Okay, they will be sending my review, like how am I working, to APRA, which is Australian Health Regulation Practice Agency, every 3 months. So if they find it deemed that, okay, this person is eligible enough, then they'll be promoting me to the level 2 supervision then. Okay, so, and then if I take my clinical, I can just go with the provisional or the general registration. There is no time limit. There's no time limit. Can we get JMO after AMC1? Yes, you can. Have you got it, sir? Yes, you can. I just explained. No? That's how I got it. Can I practice in UAE if I have complete registration? I don't think so, but you need to research more in that. I don't think so. If you have in Australia. I think as existing you can, but I don't think directly. I think you need to do some. I'm sorry, I have no idea about UAE. I won't fumble about it. So even without FMG, if I work in private, that is in a world directory, I can get internship in Australia. Am I right, sir? Yes, you can. You can. But it's very difficult, huh? It's not mandatory to do internship in India. But don't you need to get your degree valid first? That is why you need the FMG, right? Okay. Are you able to get EPIC verified? See, what I would suggest you, Dr. Tanushri, is you go with EPIC verification. Okay, you start with your EPIC verification process. Okay, you can contact the counselors of med exam. They will help you with that. Okay, go with the EPIC verification. If you're able to get the EPIC verification, then yeah, you get verified. Yeah, you get, then it's great. Okay, yes, you can apply for internships. But it's very difficult to get an internship in Australia. That I'm saying. You are eligible. Yes, you can. Have you got job service? It is tough for MCQ pass. It is very tough. It is very tough. You need to form a lot of network. But I think that is beyond the scope of this seminar right now. How to get a job. If the program manager or something, they set up a seminar for getting a job, then I'd be more than happy to talk about it. Can we go to UK if we have a complete registration? You like ulta pass. But why would you want to do it? Why would you want to do it? I don't understand, Dr. Shubham. Because it is other way around. I hope you know it. The maximum doctors that's coming to Australia these days it's from UK. Okay, most of the doctors from the UK are migrating to Australia. Me myself, I was preparing for plan actually, right? I had also registered for plan 1, but then I cancelled it. Okay, but I'm talking about just last year September only. This is just exactly 1 year back. Okay, so I don't see the point of migrating to UK after doing it Australia. But yes, you can. To answer your question, yes, you can. However, it's a mandatory internship here in India for FMGEs, just for knowledge. Okay. Okay, so I think Dr. Ezra, should we wrap it up now? I'll hand it over to you.
Yes, thank you so much, Dr. Chinmay, for this webinar. I guess everything is clear now. Now we can end the
Yeah.
session. If you have any further queries regarding anything, you can just message us. We are always available on these numbers that we have shared with you. And if you need any kind of details, we will be more than welcome to guide you. Thank you so much all for joining us today.
Yeah.
And thank you,
Thank you
Dr.
so much,
Chinmay, for
everyone.
this wonderful webinar.
Thank you so much. Thank you so much for your coordination. Thank you so much to everyone who joined the session. Okay, we need to ask. Okay, should I drop my number over here? Okay, maybe I'll just drop my number over here then. Meeting group chat. It's +9 when I'm from India, so just add +9 within that. But just be very considerate in asking questions, because I'm happy to share my number, but people just, and please ask it in the daytime hours. Okay, I've dropped my number in the chat box. Okay, and you always have beautiful counselors over here for thieves. They would explain it to you way better than I do, because they are doing it professionally. Okay, so they would be. I just know for what I did. Okay, these people have been doing it for so many people, so many other doctors out there. So they would be better to guide you actually. Okay, then thank you so much for so very much for being a great audience, for being very interactive. Okay, you guys have been very interactive, and I hope to see you all soon in the coming sessions. Thank you so very much.